Okay guys, chapter 16, airway management. This is part 1, so that tells you we've got several to get through, so let's go ahead and get started.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
Well, I think we can understand that everything that we do has a purpose and a proper way to do it in airway management as paramedics. So let's talk about airway. Airway management, as you can see, vital to patient care. So when we start talking about vital to patient care, we're talking about establishing and maintaining a patent airway and ensuring effective oxygenation and ventilation. Both of those things are going to be vital to patient care. Why? Well, good question. Because the human body needs a constant supply of oxygen. And where that begins with is the airway. If the airway is occluded or not working properly, then we're not going to be able to get that oxygen in there. So airway or ventilation compromise will rapidly lead to acute deterioration and death as well. So we're going to talk about the respiratory system also. Just a couple of big points. Obviously, we know this, but it brings in oxygen, eliminates carbon dioxide. So, none of these things will work properly. When I say these things, I mean these vital organs will work properly if the process is interrupted. So much so that even after about approximately 6 minutes without oxygen, then we start to see some permanent death of brain cells starting to occur. So failure to manage the airway is a major cause of preventable death in the pre-hospital setting. So the mortality and morbidity, they all increase due to failure to use our basic airway techniques. We know that we want to go with BLS before ALS, improper performance of the technique. So if we're not using the techniques properly, the rush to use advanced interventions. Once again, just talking about BLS before ALS, and then the failure to reassess the patient's condition. So we need to be able to understand the importance of early detection of airway problems, and then rapid and effective intervention and continual reassessment when we're talking about airway management. So appropriate airway management, what is some of those standards? And we say open and maintain a patent airway. We want to recognize and treat the airway obstructions. We want to remove those things if we're capable of doing that. Assess ventilation and oxygenation status. Administer supplemental O2. Provide ventilatory assistance. And then these steps must be performed in order. So we don't want to bypass steps that need to be done. However, if some of these steps do not apply, then we want to go ahead and bypass those. So we're talking about airway obstructions and those kind of things. Let's talk about anatomy real quick. So you'll see we're talking about all anatomic structures. Talking about the upper airway, all anatomic structures above the glottic opening. So way back in there and down here in the right below the epiglottis. Once we start talking about passing through those cords, that's what we're talking about. Everything from there north is going to be the upper airway. So when we talk about all these structures, we have the tongue, which went with an advanced airway, or even some BLS airway. The tongue must be manipulated. What happens with it, it tends to fall back into the posterior pharynx in unresponsive patients, and that's where you end up getting those snoring respirations, and it starts cutting off air as well. And then the uvula extends from the soft palate in the posterior oral cavity and the base of the tongue. One of the things that does, though, it helps prevent, when we're talking about the uvula, it helps prevent food from going up the nose. It also triggers a gag reflex whenever that's stimulated. Into the pharynx, so the muscular tube that extends from the nose and mouth to the esophagus and the trachea. That's composed of a few different little things there. We're talking about the nasopharynx, the oropharynx, or even the laryngopharynx or the hypopharynx. And then the thyroid cartilage. So you might be wondering, why are we going over all this anatomy? You know, we have already went through A and P, but all the pieces that we're looking at right now are pieces that we need to know in advanced airway management. When we start talking about the epiglottis, you know, we know that we want to manipulate the epiglottis in one way or the other, depending on what blade you use. When we start talking about the lower airway, we're talking about surgical or needle crikes, and we need to be familiar with these structures. So the lower airway extends from the glottis to the pulmonary capillary membrane. So all the way down to where that work is being done of those internal respirations. So the larynx, the complex structure formed by many independent cartilaginous structures, marks where the upper airway ends and the lower airway begins. And then the thyroid cartilage. So that you can see here kind of this shield-shaped structure formed by two plates that join in a V shape anteriorly to form the laryngeal prominence. It's also known as the Adam's apple. Typically, you'll see it more pronounced in men. Now, if someone has a short neck or they're quite obese, it may be really difficult to locate that structure and that landmark. It's suspended from the hyoid bone by the thyroid ligament and then directly anterior to the glottic opening. And then we get down to the cricoid cartilage. It lies inferior to the thyroid cartilage and forms the lowest portion of the larynx, more prominent in females. And then the cricothyroid membrane. So we mentioned that we'll be doing some things with surgical airways and all of that, and this is the site that we'll be looking for, that we'll be using. That's located between the thyroid and the cricoid cartilage. So, that's the site for the emergency surgical and non-surgical access to the airway. Now, it's bordered laterally and inferiorly by the highly vascular thyroid gland. So that's once again why we want to be pretty diligent with our landmarking, as well as thoughtful with the way that we do these processes. So here's where we're looking at the glottis. We start to see these vocal cords. That's where we're going to pass that tube through whenever we move on to that advanced airway. It's the narrowest portion of the adult airway, the glottis is. So those vocal cords, they're at the lateral borders of the glottis, as you can see them there. The epiglottis is located at the superior border of the glottis. So when we start talking about endotracheal intubation, it requires visualizing the epiglottis, the glottis, the vocal cords, all of those things before inserting the tube. And then the trachea immediately descends into the thoracic cavity. And one thing to remember is it's not a straight tube, which is really a big point to understanding when you're placing an endotracheal tube, or you can actually right main stem them. So what we're saying is you can put that tube just on one side versus both. So let's talk a little bit about ventilation, oxygenation, and respiration. It seems like they're interchangeable terms. However, they are quite different, every single one of them. So we see that the respiratory and cardiovascular systems, these guys all work together. A constant supply of oxygen and nutrients is delivered to every cell via this system that we're talking about. And then also, because we're sending in unloaded oxygen, we're also going to be getting waste products. They're going to be removed from every cell using this system as well. Let's talk about ventilation. So that's just the physical act of moving air in and out of the lungs. So inhalation, that's the active process. It's a muscular part of breathing. And then exhalation is just a passive process. It doesn't normally require, any muscular effort. It just happens. And then oxygenation. So that's the process where we talk about we're going to be loading those oxygen molecules onto the hemoglobin molecules in the bloodstream. However, it does require an adequate FiO2, or the percentage of oxygen in the inhaled air, is what we're saying when we say the FiO2. So you can see here where we're on the little slide there, where O2 is being loaded on, and O2 is being released to the cells as it gets to where it's needed. And then that respiration. So the process of exchanging O2 and CO2, and I misspoke just a little bit. Now we're talking about respiration, so unloading and offloading some of those things. When we were on our last slide, we still are talking about unloading and offloading. However, this was going to be going to the cells. So the external respiration, also called pulmonary respiration, process of exchanging O2 and CO2 between the alveoli and the blood in the pulmonary capillaries. So as we're breathing in that O2, it's onloading there, and then the CO2 is offloading to be able to be expelled. And then internal respiration, also called cellular respiration. That's where that exchange of O2 and CO2 between the systemic circulation and the body's cells. So it's getting offloaded to those cells. Now, pathophysiology of respiration. So multiple conditions, when we're talking about this, can inhibit the body's ability to effectively provide oxygen to those cells. The disruption of pulmonary ventilation, oxygenation, and respiration will cause immediate effects on the body. So as we start losing O2, and especially as we start gaining CO2, you can quickly and certainly notice changes within your patient. So it needs to be recognized, it needs to be corrected immediately. It's important to distinguish a primary ventilation problem from a primary oxygenation or respiration problem. So what we're saying is it's important to understand, is it an air getting in issue, or once it's in, are we able to unload and offload properly and do all the things that's needed in that process. So every cell, we've seen the little stopwatch before when we go through our BLS classes, but every cell needs a constant supply of oxygen to survive. Some tissues are much more resilient than others, but sufficient levels of external respiration and perfusion are required. So you can see on there we have different times: cardiac irritability to brain damage not likely to possible to very likely, and then where my head is, it says more than 10 minutes irreversible brain damage. So hypoxia, well, obviously a big thing when we start talking about airway management and not allowing our patients to become hypoxic. So the tissues and cells, they do not receive enough oxygen. And once that starts happening, then death can occur quickly if it's not corrected. Now, how we start to see some of these things is we start to see varying signs and symptoms. So depending on the onset and degree of tissue damage, it often depends on the quality of ventilations. Early signs, as we've learned through EMT and if you've gone on through advanced, we know that some of those early signs, they include restlessness, irritability, apprehension, tachycardia, anxiety. Late signs, however, include mental status change, a weak pulse, and cyanosis. So those are things we really start that makes it quite easy to notice. If you're not paying attention, you may not really notice some of those first things, but as we get into weak pulses and cyanosis, mental status changes, we can really start to see some big changes that should be able to stand out to us. Often, responsive patients will report dyspnea and not be able to speak in complete sentences. So we start talking about 2, 3, 4-word sentences. They're having to take a deep breath in between as they're continuing on their sentence. So it's best to administer oxygen before these signs and symptoms appear for these patients. Now, you may see this somewhere labeled as a VQ mismatch, but it's a ventilation perfusion ratio mismatch. So what we're saying is air and the blood flow, they're directed at the same place, but ventilation and perfusion must be matched up appropriately to be able to get the oxygen to the blood and then onloaded, offloaded, all of those things that we've already kind of mentioned to. Failure to match that ventilation and perfusion, or VQ mismatch, that contributes to most abnormalities in oxygen and carbon dioxide exchange. So when it is compromised, but perfusion continues, so when we're talking about ventilation is compromised, but perfusion continues, so the blood passes over the alveolar membranes without gas exchange. So CO2 is recirculated back into the bloodstream, and once again, that just results in a VQ mismatch. As you can imagine, that could lead to some severe hypoxemia if it's not recognized and treated. And we'll talk about that a lot, that we've got to be able to recognize these things so we can treat them. So we want to try to stay ahead of this before this stuff happens. But now when perfusion across the alveolar membrane is disrupted, then less O2 is absorbed into the bloodstream. So less CO2 is also removed. Once again, VQ mismatch. So that can lead to hypoxemia as well. And we need to get immediate intervention needed to prevent more and more damage, or this just ends up evolving kind of into up to and including death when we start talking about it. So factors affecting ventilation. So patent airway is critical for the provision of O2 to tissues. That patent airway is one of the most important things. And when we're saying patent, we're just essentially saying, air is flowing in, air is flowing out without obstruction. Now, several things can cause these obstructions, and we'll talk about them. Intrinsic and extrinsic factors can start causing these airway obstructions. So this gives you just a little picture of kind of VQ mismatch. Once again, my head's in there, and you can kind of see where we have a change in our pressures. But when you look over to your left, you'll notice that everything is moving, north and south, and things are being onloaded and offloaded. However, when we go over to the right, where we have some damage, whether there's some fluid there or some gunk or damage or whatever it is, it's unable to offload and onload the way that it needs. So when we talk about those intrinsic factors, you notice infection, allergic reactions, unresponsiveness. One of the most common obstructions in an unresponsive patient is going to be the tongue. We kind of mentioned it before about making sure that we're able to control that tongue as we're doing this. But there's a lot of medications that can depress the central nervous system. Of course, trauma to the head and spinal cord, neuromuscular disorders, obviously neuromuscular blocking agents. So if we're starting to do some RSI, or for some reason that they've been using these, and then allergic reactions, obviously swelling or angioedema can obstruct the airway, and then bronchoconstriction can certainly decrease that pulmonary ventilation as well. And then extrinsic factors. So trauma, foreign body airway obstruction. So trauma to the airway or chest, that's going to require immediate evaluation and intervention as well. Blunt or penetrating trauma, even burns, can start to disrupt that airflow as well. What you can see is it can quickly result in some oxygenation deficiencies. So trauma to the chest wall can lead to inadequate pulmonary ventilation. So kind of an example, a patient with numerous rib fractures or a flail chest, what you'll typically see them do is breathe shallowly, or what you might call respiratory splinting, and it's helping them to alleviate the pain from taking a big deep breath. However, you can see that with that decreased pulmonary ventilation, there's going to be some issues there. So really good ventilatory support is going to be crucial in that type of patient. Hypoventilation, that occurs when CO2 production exceeds the CO2 elimination. So remember, as we've talked before with O2 and CO2, essentially in normal conditions, those are kind of inversely proportionate. So the more O2, the less CO2, and the less O2, the more CO2. So here we're talking about hypoventilation occurs when CO2 production exceeds CO2 elimination. That could be from air trapping or a number of medical conditions. However, it can also be from drug-induced bradypnea, someone's breathing slowly. And the next one would be hyperventilation. So that occurs when carbon dioxide elimination exceeds the carbon dioxide production. So they're breathing, as you see this guy breathing very fast, blowing off all that, getting in more and more O2, and also releasing more and more CO2. So the thing is, that can be, as you can see, the little guy there, he's doing this himself. However, that can be some medical conditions as well. We've all seen those blood sugar conditions where people are breathing deep and fast, trying to normalize, kind of get in that homeostasis area of O2 and CO2. However, they're unable to do that. They're unable to do it with just that mechanism. Factors affecting oxygenation and respiration. So there's some external factors when we talk about that. Atmospheric pressure, obviously, at high altitudes, percentage of O2 remains the same, but partial pressure decreases because of the total atmospheric pressure. Now, here in Oklahoma City, we're looking at about 1,200 feet above sea level, so probably not going to run into a lot of these, but you may very well go and work somewhere that has a much higher elevation than that. Now, what we might see is some closed environments, so they have a decrease in ambient oxygen, when we're talking about for an example, would be trenches and mines and things like that. Obviously, some farming things. And then toxic gases, they displace the oxygen in the environment as well. So CO inhibits the proper transport of oxygen to the tissues. Some internal factors, so conditions that reduce the surface area for gas exchange, they also decrease the body's oxygen supply. Medical conditions may also decrease the surface area of the alveoli by damaging them or by leading to an accumulation of fluid in the lungs. And then non-functional alveoli, they inhibit the diffusion of oxygen and carbon dioxide. That can be anything from surfactant issues, and that seems like it might be just a pediatric issue, but there are a number of things that can cause surfactant issues within the adult population as well. Submersion victims can be a problem. Patients with pulmonary edema have fluid in their alveoli. Lots and lots of things that can cause these internal factors causing this fluid in there and not allowing that gas exchange that needs to happen. Hypoglycemia, so oxygen and glucose levels both decrease when we start talking about this. And then infection, so that infection increases the metabolic needs, and we mentioned homeostasis. It disrupts that homeostasis. And then things like hormonal imbalances. So if insulin levels decrease, then the cellular uptake of glucose will decrease. That results in ketoacidosis. So once again, we'll start seeing reasons of what's going to affect that oxygenation and respiration. Now, circulatory compromise. That leads to inadequate perfusion. Oxygen demands will not be met when we're talking about this. Circulatory compromise, so whether it's a vessel or what's within the vessels, obviously blood, then there can be some kind of issue. And then obstruction of blood is typically related to, when we're talking about traumatic injuries, everything from simple or a tension pneumo, open pneumo, hemopneumothorax, even a pulmonary embolism. All these things inhibit the gas exchange at that tissue level. So circulatory compromise, still continuing on there. Conditions such as heart failure, tamponade, all of those things inhibit the ability for the heart to effectively pump oxygenated blood to the tissues. So blood loss and anemia reduce the oxygen carrying ability of the blood. If there's not enough blood there, then it's obviously not going to be able to carry as much oxygen as it needs. Or if they're anemic, then the red blood cells are going to be at a decreased level and unable to perfuse everything that needs to get perfused. So when that body's in a state of shock, oxygen is not delivered to the cells efficiently. It doesn't matter necessarily what kind of shock, hemorrhagic shock, vasodilatory, both forms of shock result in poor tissue perfusion that leads to anaerobic metabolism. So that kind of leads us into acid-base balance. We're talking about not being able to be perfused properly, so we start to see some of these changes that happen within the body. We start to see things becoming acidotic, or before when we saw the little guy that was breathing really fast, they can become alkalotic. All of these things, acid-base balance is just a big thing that we're hoping that the body keeps us within that level of homeostasis. So hypoventilation, hyperventilation, and hypoxia all disrupt the acid-base balance. And as we've mentioned before, these things can lead to a rapid deterioration as well as death if it's not corrected quickly. Now, more than just breathing, we do have a couple mechanisms here to maintain homeostasis, and we've used that word. If you don't remember, we're talking about kind of just towards that stability in the body's internal environment. So it's that balance between acids and bases and all of the things working just right, that homeostasis, just trying to stay within that kind of the operating level or what's best. So The fastest way to eliminate these excessive acids, that's through the respiratory system. So it can be expelled as carbon dioxide from the lungs. Slowing respirations will increase the level of carbon dioxide in the event we're talking about kind of the other direction of pH. But however, the next way, the renal system, it regulates it by filtering out more hydrogen and retaining bicarbonate when needed, or doing the reverse. So the fastest way to eliminate excessive hydrogen ions is to create water and carbon dioxide. Once it does that, it can all start to become expelled as gases from the lungs. So anything that inhibits respiratory function can certainly lead to acid retention and then developing into acidosis. Alkalosis can develop if the respiratory rate is too high or if the volume is too much. So the main clinical presentations of acid-based disorders that we see, kind of the main, remember we just said the main ones, we have respiratory acidosis and alkalosis, and then we have metabolic acidosis and alkalosis. Now depending on there's these fluctuations within pH as to what we've been talking about due to available bicarbonate. Those can result in metabolic acidosis or alkalosis versus the respiratory system trying to onload and offload, get rid of things and adjust it as necessary. Fluctuations in pH due to respiratory disorders, they result in respiratory acidosis or alkalosis, as we mentioned. So patient assessment, airway evaluation. Let's take a look at this. So here's a really important point. The quality of assessment determines the quality of care. So if you're not doing a good assessment, if you're missing things as you do your assessment, then that will determine the quality of your care, because if you don't recognize that they have snoring respirations, you don't recognize that they're becoming hypoxic and all of those things, then that can certainly become an issue for you. Or really more for the patient, if we're going to be honest. So let's talk about assessing airway patency. So that you want to determine if the patient's airway is patent. An unresponsive patient has a compromised airway until it's ruled out by careful assessment. So I think it's probably safe to say if they're unresponsive that you should probably just consider it a bad airway until ruled out otherwise, until proven otherwise. Signs of compromise in an unresponsive patient, as we talk about, snoring, vomitus draining from their mouth, gurgling sound heard during breathing, secretions pooling in the patient's mouth. Remember, they're unable to protect their own airway, so that's going to be a real problem. So especially if they have a depressed or absent gag reflex, then now we're talking about very high risk of aspiration, and that just leads to chronic problems. So recognizing an adequate breathing. So first off, we want to talk about what's good, and then we'll kind of mimic that and look at an inadequate airway. So an adult who's responsive, alert, and able to speak, typically between 12 and 20. Just because they're below 12 or just because they're above 20 doesn't mean that it's an inadequate airway. We need to see signs and symptoms with that. So, we want to look at cyanosis and all, maybe their positioning and all of those things. We want to make sure that they have a good adequate depth or a tidal volume, and then a regular pattern of inhalation and exhalation. And then, of course, clear and equal breath sounds. And so, whenever we start seeing these changes going from this, many times they can be very subtle, whether their breathing rate is changing or the depth is changing. So this is something that I just added in. You won't find it in your book, but I found it interesting and intriguing. Patients don't suddenly deteriorate. Healthcare professionals suddenly notice. So many times, I want you to think about that, as well as maybe on a ride that you've been on a call that you've been on, when you've been at the ER and things that you've seen. Some of these physiological changes we're not noticing. So the heart rate change, the respiratory rate change, O2 sat, pressure, mental status, all these things can just occur slowly, and if we're not doing a good assessment/reassessment, it's very easy to miss these. However, these things can be early warning signs, so they can be subtle and go unnoticed if we're not monitoring and assessing them. So sudden noticing, often due to delayed recognition. So we're talking about a gap in monitoring frequency or something to that effect. Maybe you haven't paid attention to someone because you've been worried about paperwork, or you're talking to your partner or whatever, as well as communication failures because we're just not paying attention. We're not communicating with our patient. We're just worried about everything else, as well as underappreciation of early warning signs. So we start to see those subtle changes and we don't really pay a lot of attention to them. So, the next point that I have on that is just kind of that how important it is for your monitoring early warning system. So hopefully all of your monitors are set with alarms to tell you when pressures drop and O2 sats drop and those type of things. There's also human factors in healthcare. So let's just talk about, you have people that are burnt out and they're not paying attention to someone. Maybe they just don't even like that person. Maybe they've ran on them 3 times in the last 2 shifts. Whatever it is, there's just a lot of human factors that will easily overlook these things. So kind of just some examples, sepsis is an example. So they often show early signs like some mild tachycardia or even fever hours before becoming really ill. Without early recognition, those things can escalate into septic shock. Respiratory failure, so patients can exhibit increased work of breathing, subtle O2 desaturation, or changes in mental status before they have that critical decline, and we start to see that, whoa, this guy's sick. So that's kind of a soapbox. We'll move on to this. We got the recognizing inadequate breathing. So breathing rate of fewer than 12 or more than 20, as well as, like we said, adequate, that are moving enough air. Just once again, just because they're lower than 12 and greater than 20 does not mean per se that that's inadequate breathing. Depending on what the patient's condition is, if they're a trained athlete, they could certainly breathe less than 12 times a minute and perfusing everything at 100%, their O2 sats 100%, their end-tidal's great, all of those things. However, you see the next point, maybe they have some cyanosis or something, or doing some shallow breathing, or a regular pattern of breathing. Maybe they have altered mentation. Now that's what we're talking about when we link it up to the rate that might be just a little bit off. As well as you walk in and you see someone that's in, like an upright sniffing position or even a tripod position, that should give us a pretty good hint that there's something going on. So there's a lot of causes, as you see listed here, and you can probably list 20 more. Just a few that we talk about in our curriculum: severe infection, trauma, brainstem injury, noxious or oxygen-poor environment, renal failure, lots of reasons that can cause inadequate breathing. So airway management tips. Airway management steps, not tips. Open the airway, clear the airway, assess the breathing, provide appropriate interventions. So we're not saying that you immediately move to intubation, because remember, BLS over ALS. We always got to start with our BLS first. Our evaluation includes visual observation, auscultation, palpation. So we want to see, see how they're sitting, see what their skin tone looks like. We want to listen to lung sounds, listen for fluid, listens for wheezing and rhonchi and rales and all these things. Palpation, we want to check to see maybe do we have adequate chest rise and fall? Are they symmetrical or asymmetrical? So there's lots of ways to go ahead and notice that someone has inadequate breathing. Now when we look at this person, we see them in kind of a tripod position. They can, maybe they've been experiencing orthopnea also. So when we say that kind of difficulty breathing or dyspnea, that occurs when they're lying flat, so they're unable to lie flat. Adequate rise and fall of the chest, that's some more inadequate breathing signs and symptoms. Patient gasping for air, obviously. Skin color, nostrils flaring, lots of things. Breathing through pursed lips, retractions, all of those things. And there's other ones you've all gone through as an EMT. So the signs. Now, this is not a duplicate slide. I'm not sure why. It has fewer than 12 or more, plus dyspnea. So recognizing inadequate breathing. Rate fewer than 12, more than 20, and the presence of dyspnea. Irregular rhythm, diminished, absent, or noisy breath sounds, abdominal breathing, a reduced flow of exhalation, unequal or inadequate inadequate or unequal chest expansion, increased effort of breathing, lots and lots of issues. So feel for air movement. We talked about palpation. Observe chest for symmetry. Lots of things that we want to do. Assess for pulsus paradoxus. So we're talking, when we say that, it's a systolic blood pressure that drops more than 10 millimeters of mercury during inhalation. So you can detect a change in pulse quality or even the disappearance of a pulse during inhalation with this. These are all signs of inadequate breathing. Then we want to ask some things. What was the trigger? What is there a known cause? Was the onset sudden or gradual? The duration, was it constant or is it recurrent? All of these things, all of our kind of going down our OPQRST if we're able to apply those. Evaluate protective reflexes. So that's going to be very important, because if they're unable to protect their own airway, then that you can see how that gets to be a thing. So coughing, sneezing, gagging, all of that. Sighing is one as well as it lists hiccuping. My understanding is if it's a chronic issue, if it's a hiccuping that someone has been doing for a long time, then it can become something, it can be clinically significant. They can have everything from a brain issue to there's all kinds of things. But many patients that have serious injuries or illnesses, they can present with changes in their respiratory pattern. So those are some more things that we're paying attention to. Now, assessment of breath sounds. So auscultate the breath sounds with the stethoscope. Obviously should be clear and equal on both sides, front and back, or anteriorly and posteriorly. Compare each apex of the lung with the opposite apex, the base with the opposite base. Breath sounds, they're created as the air moves through the tracheobronchial tree. So depending upon the size of the airway, that can determine the type of sound. There's lots of different ways that that airflow can be diverted almost or changed. And then duration, so length of time for inspiratory and expiratory phase. Normally you see the I/E ratio, inspiratory versus expiratory, is 1:2. So say it takes 1 second for inspiratory, it should take 2 for expiratory. When the lower airways get obstructed, expiratory phase may be 4 to 5 times as long. They're just trying to blow off that CO2. And you see these I keep pointing, I'm sorry, on my computer I keep pointing at the little things on the pictures, and you guys can't see them, but you notice the little like sharp angles and everything. And so you have tracheal and bronchial vesicular sounds, and you'll notice as it talks about throughout the curriculum that these are high pitched or it might last longer. And so take a look at that. The pitch higher or lower than normal, so we're talking about stridor or maybe wheezing. Intensity of the sound depends upon the airflow rate, constancy of flow throughout the inspiration, obviously their position, site selected for auscultation as well. You may put your stethoscope, on someone's chest and maybe not hear any wheezing. However, you put it up on their trachea and you hear a lot of wheezing. So or vice versa. Wheezing, rhonchi, crackles, these are all abnormal breath sounds. Stridor, obviously a pleural friction rub. So when we start talking about wheezing, kind of that continuous sound as those airflow, not as the air flows through constricted lower airway, high-pitched sound can be heard on inspiration, expiration, or both. When we talk about rhonchi, that was our next one, continuous low-pitched sounds. So indicates mucus or fluid in a larger lower airways. It can be very deadened or dull. It can also sound really junky as well. It just kind of like you can just hear it gurgling and stuff. Just you just kind of think gross, and that might be some rhonchi. Crackles, or you may hear me use the term rails quite a bit. Occurs when the airflow causes mucus or fluid in the airways to move into the smaller airways. So tends to clear with coughing, but it can also be heard with collapsed airways or even alveoli when they pop open. And we talked about stridor, so results from foreign body aspiration. It can be infection, swelling, disease. We're getting into the winter right now, so you can definitely hear some stridor around here. You get some of these kids with croup or something. Loud, high-pitched sound typically heard during inspiration. So stridor. And then a friction rub results from inflammation that causes the pleura to thicken. So surfaces of the visceral and the parietal pleura, they start rubbing together. Typically with that also there becomes maybe some stabbing pain. It creates some stabbing pain with breathing or any movement of the thorax as well. Quantifying ventilation and oxygenation. So how do we quantify it? Well, one of the ways we can use some pulse ox. So measures the percentage of hemoglobin in arterial blood that is saturated with oxygen. And that's not completely accurate. It's just measuring how saturated those hemoglobin are. Most pulse oximeters, to my understanding, are not going to be able to detect the O2 through CO. However, it's just looking, there's no reason to think that they have CO poisoning unless they've been in an enclosed area or been exposed to a lot of CO. So if you see 99% and they're pink, warm, and dry, there's no reason to think that it's inaccurate. However, if their color looks kind of junky and they're kind of a little altered and it's saying 99 to 100%, that may or may not be a good person to believe. You can see the normal SpO2 greater than 95%. That's kind of the benchmark that we use. So used for monitoring oxygenation status during intubation attempt or suctioning, as we're talking about this pulse ox. Now, we mentioned 95% is where we want to be or greater. Less than 95% in a non-smoker, it suggests hypoxemia. That's something that's probably worth looking into. Less than 90% signals a need for some pretty aggressive oxygen therapy. However, if they are a lifelong smoker, they're probably used to walking around in the high 80s or low 90s. Not that they still don't need oxygen. I'm just saying it may not be an emergent situation like with a person that has not been smoking. And then there's lots of situations that you can use pulse ox for. So monitoring oxygenation status of a patient during an intubation attempt or during suctioning, identifying deterioration in the condition of a trauma victim, deterioration with a patient with cardiac disease, high-risk patients with respiratory problems, obviously, orthopedic problems, lots of things. So erroneous results may result from bright ambient lights, patient motion, poor perfusion, nail polish. Nail polish is a big one that you may see just because it blocks kind of the way that it reads. So types of hemoglobin. Oxyhemoglobin, that's the one that's loaded with it, and then reduced hemoglobin, that's hemoglobin after the O2 has been released to the cells. So normal SpO2 values can be observed in the presence of methemoglobin and carboxyhemoglobin, even though the body is not receiving sufficient oxygen. So when we talk about arterial blood gases, because we're starting to look at some of these things, we're starting to look at how their hemoglobin is saturated and starting to look at some numbers here. So ABGs, really the most comprehensive quantitative information about the respiratory system is gathered from getting ABGs. However, we're not pulling those on the truck currently. I wouldn't expect that we really would. It's blood's obtained from a superficial artery. It's analyzed for a number of things, for pH, for PaCO2, arterial partial pressure of carbon dioxide, or PaO2, arterial partial pressure of oxygen. Then HCO3 is bicarb, and then base excess that indicates acidosis or alkalosis, and then of course our O2 sat. So a lot of different values here that are going to be used when a person is looking at ABGs. Now, last piece here, so hang with me. End-tidal CO2. This is probably one of the biggest changes in EMS that's really caused us that we've gained a lot from. So end-tidal CO2, maximal amount of carbon dioxide that leaves the body at the end of the exhalation. So your normal levels should be between 35 and 45. Now, when we start talking about this, we've got a lot of applications when we talk about end-tidal CO2. So it can indicate adequacy of perfusion, the effectiveness of chest compressions, even the return of spontaneous circulation. And we're going to look at, you'll see here, there's a few patterns that are not in your book, that was just placed there. And we're going to go over a few of these also that I've placed in here. So increased reading expected with inadequate ventilation. If someone's not ventilating well, meaning they're not putting in a lot of oxygen, it would be normal to think that they probably have a greater than 45 millimeters of mercury end-tidal reading because they have inadequate ventilations. Now, a lower or less than 35 reading expected with a fast respiratory rate, hyperventilation. And then if a patient obviously is in cardiac arrest, perfusion ceases altogether and cellular carbon dioxide production stops. So perfusion is generated by the chest compressions to resume CO2 production and increase end-tidal CO2. So when you're looking at a patient that is getting chest compressions done, the more effective the chest compressions, the higher the end-tidal CO2 will be. So as you can imagine, just almost with this particular situation, think of a vehicle that's just been sitting there for quite a while, just building up a bunch of gunk in the engine and a bunch of gunk into the tailpipe. And you start it up and it just blows all of that out. That's kind of similar here. ROSC will result in a really abrupt and sustained increase in end-tidal CO2. So you're just going at this very low, 0 to 10 level or whatever, wherever it's at, and then you have this sudden increase and it's able to be maintained. We may have ROSC. That's going to be someone to check on. So low end-tidal CO2, despite adequate chest compressions, you start thinking maybe severe acidosis or a minimal CO2 return to the lungs. So end-tidal CO2 also can detect carbon dioxide in exhaled air. So types of monitors include colorimetric, digital waveform. I said also, but that's what we're talking about, so not also. Capnometer, that's a numeric reading of exhaled CO2. I don't know that many people are using these anymore. As well as the colorimetric devices that are out. And I don't think I have a picture of one, but the one that is purple and gold, if you've seen those, gold is golden. So you put those on immediately after you get somebody intubated, and you get a couple of breaths through there, and depending on the color change, it will show you if your tube is good. Now everyone's running off capnometry, and you're able to get an immediate reaction for the exhaled CO2. So here, waveform capnography, that's what we're just talking about, real-time information. So it's almost at an instant. It immediately tells you. One of the nice things of capnometry versus, like say a pulse ox, it's been shown that you can have up to a 30-second lag within pulse ox, depending upon circulation and perfusion. Within this, there's no lag. This is all just real-time information. So you see it displays a graphic waveform. Many portable monitor defibrillators provide a numeric reading and a waveform. When we say waveform, we're talking about waveform capnography. So you have it on cannulas, also nasal cannula device, so sampling lines connected to the cardiac monitor, obviously. So key features, the contour, the baseline, the rate and rise of the carbon dioxide level. We're going to look at some of these things. So here, normal capnographic waveform phases. So we've got phase 1, A through B, so it's known as the respiratory baseline. That's the initial stage of exhalation. Now, if you're thinking, it's at the bottom and it's during exhalation. There's a reason for that, because once you get exhalation, you would think that you would have an immediate, if we're talking about real time, we would have an immediate rise in end-tidal CO2. However, we don't. Go back to your A&P and EMT even, and what's happening is that air that's in the dead airspace, that somewhere around 150 cc's of air is being brought out. There's no CO2 in there yet that hasn't been ran through the respiration cycle, so there's no rise in the slope. So that's why you'll notice through A and B that it's more flat than anything. And then phase 2, B and C, expiratory upslope. Then you have the phase 3, expiratory or alveolar plateau from C to D. and then phase 4, D to E, inspiratory downstroke. So as they're breathing out, so you see that immediate rise from B to C, and that's after they get rid of that dead airspace. Now they're hitting the CO2 is hitting the detector, rising it up to hopefully the normal ranges. That's that's around 35, it looks like, probably. And then you have just that pause, because that's the alveolar plateau, so it's emptying itself out. And then we go D to E, and that's the inspiratory downstroke, so they're starting to breathe air in again. So we measure two things here. We have the waveform duration, or the width, and that's the duration of the ventilation, and then the space between the waveforms, or the respiratory rate, and that can be kind of a time or just the rate type of graph. So a couple abnormal ones that are in your book. You see hypoventilation. Hopefully it makes a little bit of sense. When you look at this, you see how high it is. What is that? It's over 50, so we're probably looking at 70 or 80. However, through this, we don't know the duration of this, but say it's a 6-second strip, then we've got 2 breaths. So there's a lot of CO2 being expelled. However, there's not many breaths that are going through there. And then the one below it is a hyperventilation. So it's down low. However, you see many, many, many breaths. So I don't know what's there, 15 breaths maybe or something. Someone hyperventilating. So these can come from a variety of factors. Here, probably maybe one of your first thoughts is, at least for me, whenever I look at the hypoventilation, is probably some type of overdose or something to that effect. So it's causing them to breathe very slowly. You get down into our hyperventilation, could be just an anxiety attack or something. But you notice with the slow rate, the bradypnea produces a long alveolar plateau and longer than normal intervals between waveforms. So you have that long alveolar plateau, the top part that just continues to go and continues to rise. So with respiratory depression, things like that, that's what will cause that, as well as you get down into the bottom onto our second one, and you notice just very short and rapid breaths. Abnormal capnographic waveform. So this one is rebreathing previous exhaled CO2. You notice a couple of things that are listed: inadvertent extubation or tubing obstruction. The one thing I want you to notice is when you look at it, it starts out at 0, but it doesn't return to 0. So that's why it's called it could be rebreathing. They're rebreathing the CO2. So it can be an inadvertent extubation, tubing obstruction. There's a number of reasons. It can be a monitor issue as well, that it's not allowing the gases out, so they're always just staying in there. Not all of it, obviously, but you notice that it never returns back to the baseline. So it does climb a little bit higher and higher because it's just adding more onto the level of CO2 that they have. Now these next few are ones that are not in your book, but we can talk about them if we want to talk a little bit more about them. But this is just bronchoconstriction. So you notice whenever you look at it, first off, you hear a lot of people that whether they even know much about capno or not, they'll know that the shark fin is bad. Shark fin is bad. So one of the biggest things that you notice within this reading is, first off, it has a delayed upstroke. So as you see, it goes from normal to moderate to severe. You'll notice that delayed upstroke. It has kind of a shark fin appearance. What's going on is within you're getting the bronchioles are being constricted, not the alveoli, but the bronchioles. So how air goes in and air goes out. To help correct that, you get a longer exhalation phase, and you start to trying to force it out. Now, one thing you'll notice when you see moderate obstruction, kind of has that. One thing I didn't mention when we go back. Hang on, let's go back here real quick. When we look at this normal one, we really want to see more of a square than anything. We should have some nice sharp corners. You notice B and D is not very sharp, but many times it is. But we want to be more sharp and more square than anything. So let's get back to our shark attack here. So when we get back here, we start noticing that we're not square at all. When you look at normal, you notice how it's pretty square. And our moderate has that delayed upstroke. as well as it's going up and starting to create that appearance, shark fin appearance. However, you do notice that at the alveolar plateau, it is still quite sharp, not as sharp as it was when it was normal. That's someone who's probably just kind of respiratory distress. Maybe, this is all, listen, you always want to follow your local protocol, so this is me just saying this, but typically that type of patient can do well with just some, like an albuterol, an ANA treatment, some O2, those type of things. However, when you lose all of those sharp corners and you progress into that rounded D phase, where you see it's more rounded, that's someone who's typically someone who's going into respiratory failure. So that's someone, if you notice that right away, that's someone you need to get prepared for. Not that they don't need an ANA treatment, not that if your protocol has them getting Solumedrol, it's not that it doesn't need that, but you also might want to grab your airway kit and get ready to have to get into an advanced airway, because typically someone with that severe obstruction is going to progress into something much more severe than our moderate obstruction. So this is a prolonged phase 4. You'll notice that the inspiratory downstroke equals the beginning of inhaling. So what we're saying is this is not whoops, I forgot I can't use my mouse. You'll notice is, maybe I can do this. Nope. So you'll notice that it's not just that nice square. You notice your expiratory phase is pretty normal. However, on the back end, when we get into D and E, it's also sloped as well. So that should go back to 0, and many times it doesn't within that prolonged phase 4. So what we're typically seeing with that, and you notice how it's got that slope, that's probably not doing a very good job of explaining it, but if you look at the little mark that says measured end-tidal CO2, you'll notice it's not square and going down straight, it's sloping down. So that should go back to 0. The thing is, what's happening typically with this is CO2 is being forced out around the tube. Could be a couple of different reasons. The cuff's not inflated enough, so you're getting CO2 escaping. Or in pediatric patients, maybe your tube size is too small as well. So maybe you had a pediatric and you put in a size 4 tube and they really needed a size 5 tube. So what I said is we need to evaluate it. So the question is it effective? So do you want to pull out a size 4 tube to put in a size 5 tube? If their skin color is pink, warm, and dry, their SpO2 is back up, their heart rate has started to normalize, that might be something that you may or may not want to go ahead and take the chance and extubate and then have to re-intubate the patient. That is a prolonged phase 4. And then you notice the notched alveolar plateau, or you'll see it's also called a curare cleft. So you'll notice that it's kind of shaped like a little M, or you'll have like a little dip in there. In the past, what we've had to do is to notice that someone was coming off their paralytics when everything was starting to wear off. You'd see them to start kind of biting down or chomping at the tube. And that's how you know that you needed to redose them. That's how you knew you needed to get paralytics going back. Well, with this, by recognizing this, what happens is the diaphragm becomes one after all paralysis. Remember, it works on every muscle except the heart. So as the body starts kicking back in, the diaphragm becomes one of the first muscles that are working, and it will start to contract a little bit, almost like a small little hiccup. What it does is it gives that little bump that you see in there. So that's a curare cleft. So that can, if you pay attention to that, that can give you a really good idea that you need to redose your meds. You need to go follow your protocol, but you need to go ahead and get that patient taken care of. That's a curare cleft or notched alveolar plateau. And then this is a sudden drop in cardiac output. So you see this and you notice everything is normal, and then all of a sudden you notice that the end-tidal just completely drops. It could be a number of things. So when it drops from a normal to a low number, the reason I put in normal is we have these things that we say are normal, but it's what's normal for a person. So what's normal to that person is, say, whatever it is, 35, 45, 50, whatever, and then all of a sudden it drops down to, say, 20 millimeters of mercury. That could be a potential decrease in cardiac output, because now everything is not working as well. It's not creating as much CO2. It's not pushing out as much CO2. Make sure you evaluate your patient in the event that you see that sudden drop in cardiac output. And there we go. That's it. That's part 1. 1 hour and 2 minutes. So that's part 1. So stay tuned for part 2.